boroughs that were hardest hit. The poorest congressional district in the United States is here at the South Bronx, and that's where I did most of my work. A very high volume, high patient acuity. So they were very hard hit at Lincoln Hospital. Good. Yeah, so this is when I was there. That red square is when I was there. So I wasn't there during the peak necessarily. It was starting to downtrend when I got there. So we were still seeing COVID cases on a daily basis, but regular cases, regular emergency room cases were starting to come back, and the volumes were pretty low at that time. So this would be kind of a typical case that we would see. We would see an older patient, usually someone with some comorbidities, coming in respiratory distress, and there would be initially when they got there, they would get vital signs. Their oxygen levels would be very low, and a bunch of different people would come in with their suits to address the patient, put them on monitors, and get the patient kind of stabilized. Sometimes these patients were transferred from many different hospitals and had no belongings with them and no family members, and were pretty confused as to what was going on, but they were not doing well. You would often get questions of, am I going to die, or where am I? And this was it was a very stressful situation for the patients who often didn't know what was going on, and for clinicians who had to go in there and help these patients. Family members were not around and not allowed in, and sometimes family members didn't know where their loved ones were because they were being transferred in all sorts of different places. So it was a pretty stressful situation. Next slide. Okay. So this is often what a chest X-ray would look like. You could see that there's what's called ground glass opacities on both lungs, and there's not a lot of room for oxygen to go. You can tell that the illness has caused some diseases and some pathology to the lungs. So this is what it looked like during its peak. This is some images that were shared with me by some of the physicians and residents who worked there. You could see that the volumes were so high that people were lined up in in the hallways and in curtains, and initially they tried using some isolation rooms to keep these patients in negative pressure rooms, but the volumes were just so high that there's nothing you could do, essentially, and the healthcare workers had to do their best to stem the tide of all these patients coming in. I want to point you towards this. You see this blackboard at some point, or this whiteboard rather. At some point, the volume was so high that the doctors couldn't keep track of the patients with the medical record, the electronic medical record, because they were coming in, every 30 seconds. So you could see that here it shows the room numbers and all the people that were intubated. Tubed means intubated on ventilators. So that just gives you a sense of how many sick patients were there during the peak. And so we did ICU rounds as well when we were there. So this is a very stressful situation for being in the ICU. This is often what you would see is a patient connected to multiple vents, multiple lines, and they weren't getting better. The mortality was very high. There was a sense of futility in a lot of the work that ICU doctors were doing because these patients were just dying, and there's almost nothing that doctors could do at this time. They would die without any family members around, and often it would be days until you even knew who the patient was. Sometimes they would come in without any identifying information, and sometimes they would be transferred. Sometimes even days after these patients would die, you would get calls from family members asking where these patients are, and you would have to tell them that they were here and that they're no longer alive. So this is a very stressful situation when I was there. Next slide. Can you go to the next? Okay, perfect. You can go, yeah, one back. Yeah, so this is another. You can get a sense of what the roles of the nurses were and of physicians who would gown up every day and come and see these patients, often who were getting worse on a daily basis. They at some point wouldn't have enough energy to speak, and they would ask. So many patients would ask not to be intubated. They didn't want to be on a ventilator. So you would be with them as they kind of got worse and worse, and their breathing would get worse, and you would do everything you can, but they wouldn't want to go on a ventilator. And so at some point they would die, and the doctors and the nurses were kind of the ones there doing the consoling, being there for the patients when there's no one else around. And I think that took a pretty big toll on the healthcare workers that I was there with. I think one of the big roles that I had there was not necessarily to see COVID patients. I did, but that was not my big role. My big role was as a relief worker. So I was there to help doctors who had been there during the crisis when it was at its peak, and kind of allow them to go home and see their families and spend some time with their families. Many of these doctors had just been staying in hotel rooms because they were afraid to visit their families. And so because of volunteers and people like myself, they were able to kind of go and spend some time with family. So one of the big takeaways, you can go to the next slide. One of the big takeaways was the mental health aspect, and that's part of why I asked Kevin to come here, and I'll ask him to speak in just a few minutes. But part of my big takeaway from this experience was the mental health aspect of how this took a toll on frontline healthcare workers, on patients, and on patients' families. So I think that's not very much spoken about, but it's very important to address and understand. All right, so let's go to the next one. So this is on one of my first days working in the emergency department. One of the most intense experiences I've had pretty much as a clinician in my whole life was these two sisters who came in their mid-70s. They had lived together in an apartment for the last 20 or 30 years, and they were just kind of living there. They both decided that they did not want to be intubated or resuscitated, and they wanted to be together. And so they came in with shortness of breath. They couldn't breathe very well. They were placed on oxygen, and they were put in a room together. And they did not want to be intubated or ventilated, and they ended up dying together after many hours in a room side by side. Multiple nurses would go in to kind of help the patients and console the patients and make them more comfortable. And I think every nurse who went in there came out, visibly crying and very distressed. So that was a very powerful experience that kind of helped me understand the mental health toll that COVID was taking on healthcare workers in New York City and really around the country and the world. And so on your lower part of your screen, you can see most patients will be seeing their families. They see them on iPads. And of course, it's the physicians and nurses and techs who are holding up the iPads, who are engaging in this dialogue between family and patient, and helping facilitate these end-of-life discussions through iPad, which is pretty stressful. and this is just kind of a picture of some of the relief nurses that came and helped us in New York City from FEMA and from around the country. And they had to be there kind of almost as relief family members because their family couldn't be there. And sometimes we didn't know who their family members were. And the patients were, just kind of decompensating. So these nurses had to take on so many roles. They had to be family members. They had to be religious figures. They had to be, consolers, really kind of everything. So it was very tough. And so psychological stress. So I was there. I had residents who were amazing, wonderful residents at Lincoln Hospital. They helped considerably. And, this is a very interesting time to go through training. This is another question I'm ultimately going to have for Kevin, is what it must be like to go through training in this time. So these were residents who are training to be emergency physicians, and they're seeing one of the worst healthcare crises that the world has ever seen during their training. So as an attending physician, you have to be, there for these residents when they're having psychological struggles dealing with all these patients and kind of this feeling of futility. And so that's a punching bag that we have there, which I found to be actually quite helpful, with a picture of coronavirus on it. So whenever the residents would come into work, they would punch coronavirus. And whenever we discharged a patient, we would punch coronavirus. So we tried to do our best. And so there's just some pictures. Okay, next. So this is just a little bit, as we know, coronavirus affects those who are the older and have a lot of comorbidities, diabetes, heart disease, obesity. So those are the vulnerable populations that we, really need to be worried about and spend some extra time evaluating and talking to and looking at their risk factors and what kind of safety net they have at home, what kind of follow-up they have, because those are the really at-risk populations. Okay, next. And so similar idea. So those with pre-existing conditions, cardiovascular disease, are the ones at higher risk. So global trends. So kind of until recently, we had this large spike, and we were getting, better with regards to cases and fatalities based on social distancing and quarantining. And then most recently, there has been some spikes in the COVID cases in various counties and states. So treatments is something that's ever changing. We have no definitive good treatment at this time. Things change all the time. Hydroxychloroquine was thought to be the end-all be-all at some point. And then that, data is showing more and more that is just not the case. So more studies need to be done, but it is not like the magic drug that we all thought it would be. So anticoagulation is very important for some patients. We're finding that patients get blood clots and clotting diseases and disorders as a result of COVID. It changes the way that blood clots, which is kind of a new facet of this disease. So we're kind of constantly learning. Convalescent plasma has been used in very sick ICU patients with some results. And then tocilizumab, an IL-6 inhibitor, has also been used in sick patients with some good results. So there's some promise, there's some hope, but there's no magic bullet as of yet. And then the latest and greatest is a steroid. As recently as about a week ago, a paper came out showing some benefit to dexamethasone, which is a steroid that we give. So in the emergency department, if a patient is on oxygen or requiring ventilatory support, we're starting to give Decadron more and more often. But the data is not definitive, so we do the best we can, and it's a little bit of experimentation as new evidence is coming out. We're starting to get a sense of which medications we can use and which we can't, but it's still tough to figure out a treatment plan for many of these patients. Okay. So the new wave is pretty concerning. Next slide. And you could see the uptick in cases in California. Arizona has seen an uptick in cases. So the United States as a whole is starting to go back up. Does this represent a second wave? Does it not? It's unclear. New York is still stable, and that's mainly because of the spike that they had earlier on that I showed you in February and March. So the death toll in New York is, by far and away higher than in California and Arizona, and that's because of their initial spike in cases. So Riverside County is a pretty hard-hit county over the last several weeks, and cases have gone up, hospitalizations have gone up. So it's very important to stay vigilant in Riverside because cases are starting to go up again. And we're definitely seeing that in the emergency department. I just had a couple sick patients the other day. It's always very disturbing when a patient asks me, am I going to make it? And you don't know the answer to that question. And you do the best you can to console and to help and to support. But when a patient asks you, am I going to make it? It's a very powerful thing to ask a provider.
Dr. Z, we have a question. What does PUI stand for on that chart?
So PUI is a person under investigation. So it means somebody we're concerned about. They have all the right symptoms. They have the right story. We don't necessarily have a confirmatory test, probably because we just don't have the swab back yet. Okay, so let's talk just a little bit about what you can do. A lot of things you can do are pretty common sense. What you do is an easier topic than you might think. So the economy. So the economy at some point will open up. It's unclear in what stages or how it will open, but it will open. And so the best way to go about dealing with COVID is to protect yourself and protect vulnerable populations. How do you do that? It is a little bit common sense. So you know who is vulnerable, people who are elderly, people who have comorbidities. So you want to limit your interactions with those people. You want to protect yourself by wearing a mask and staying away from large gatherings. If you have any symptoms at all, you want to quarantine yourself and keep yourself at home and limit your interactions with other people. Avoiding high-risk activities is pretty self-explanatory, right? So any large gatherings where there's lots of people interacting very closely is going to be a higher risk activity than if you're walking alone on a hike. Stay healthy. So supporting your immune system has been shown to help probably more than any other thing. So taking daily vitamins, exercising, sleeping, and avoiding stress. So taking yourself out of stressful situations. So people who don't sleep are very stressed out, are obese and don't exercise. So those are the ones who are going to be at highest risk. And then it's a little bit of common sense. And so now I wanted to kind of bring in Kevin. We had a very interesting discussion when we were discussing the parallels between his experiences as a medic and frontline healthcare workers in New York City, and how those two things, how we can learn from each other on how to deal with the mental health struggles, because that was the biggest thing I learned when I was in New York, is the mental health toll it took on the frontline healthcare workers. and on the patients and their families. So I wanted to let Kevin maybe introduce himself, and we can go to the next slide because these are some of the things that Kevin does.
Hi everyone, I'm Kevin Westbrook working with Dr. Z. Nice to see you all. Ross gave me a pretty good introduction there in the beginning, so I'm not going to reiterate any of, I guess, my background or credentials to speak. I think that's pretty evident. And Ross, can you go back to the previous slide? I think Dr. Z has that, he's got that hammered down pretty good. So everyone take a look there, right? What you see is you got a combat veteran sitting on the floor, all distressed. Kind of the common theme of what people accept to be the psychosocial profile of a military veteran. And then there you've got a nurse sitting there. And I think that parallel in this image in particular is almost exactly the thing that I identified in March as COVID was sort of ramping up in the United States. All right, Ross, you can click back to the next slide here. So I got some slides here. My piece is not a presentation, right? I'm gonna get you guys involved. You can answer in the chat box, and then of course a lot of questions up to Dr. Z, who I think is probably the most unique resource that I have actually to access as far as information. So go ahead and take a look here on the left side. I got a little quote from the United States Health Director, Dr. Anthony Fauci, who is he's the lead academic advising the strategy of the United States as we respond to COVID. And this is from a New York Times article that I was privileged to read in April. And they're asking him exactly what it's like being the guy in charge of the COVID response. And he says, we're in a war. I mean, I actually think this is exactly what generals or leaders in real, violent combat wars feel. And this is a man who, we'll be frank, has absolutely no idea what that's like. But given my experience and background, this dude is absolutely correct. And it is not just a narrative that the United States has put together sort of as a news media profile that everyone's just sort of talking about it. It's kind of how the United States responds to most big problems, right? You get a big thing, you go and fight it for 100 years in the desert. And that's a little bit of bias on my end that I'm talking about from that perspective, but that's how we do it. So the response to this, as far as like the news media is involved or has been concerned, has been in a war narrative. They talk about COVID as World War C. They talk about the leadership involved being these war generals, and in fact, the lead general, the general response from Dr. Fauci is in fact that he does himself feel like the war general, and that's problematic. So, given my experience being kind of tucked right in between military service and medical service, puts me in a unique perspective to see that. So as I'm watching this response sort of play out in March, most folks are responding or have been responding in a way that they look at frontline health workers as these heroes, right? These war heroes, these guys who are selflessly giving of themselves to go out there and fight this invisible enemy. And they all stand up and clap for the health workers. There's a problem with that though. So there's a big difference between soldiers who have volunteered in service to the United States with absolutely known risks involved, and then a doctor who has given his life to the service in healthcare. So my first bullet point that I'd like to bring up here, right, is that using this COVID as a war narrative is problematic, just because it sort of frames it as a single event, right? Like it's this satellite event. It occurred. The heroes, right? Superman went out and knocked it out, and now everything's fine, and we can all go back to the way things were. And that's problematic given exactly how the United States has responded to wars over the number of decades that I've been alive, and probably the entirety of the history of our nation, is that there are dramatic long-term consequences to the warriors and the soldiers who have fought in those wars. And that is exactly how it is playing out here in my perspective. And then also, I'm sure we'll get Dr. Z to talk about that too. But every single hospital across the United States is filled with warriors who have been selected for service outside of the standard volunteer strategy that the United States usually uses. Because of this, I anticipate there's a lot of folks out there speculating right now that there is a massive mental health crisis on the horizon, and it is a wave of a problem that is coming, and we are, as a nation and as a group of civilians and people inside the United States, we are not just ill-equipped to deal with that problem, but we have a long and robust history of dealing with it poorly. So, Ross, you can click over to the next slide there. I wanna ask you guys if you could just throw this in the chat. This question's out for everybody, and then Dr. Z, you can answer this one too. If I say the single most identifiable crisis in the veteran population, you guys would all respond with probably a very similar thing. So if you just throw that in the chat, what is the single most problematic issue facing the nation's veterans?
And just as a heads up, the attendees cannot see the chat, so you're going to need to read those responses off for them.
Well, we all know what it is. So I've got about 280 responses of mental health, PTSD, suicide, right? It is all the same. Everyone knows that it is mental health, PTSD, and suicide. This isn't a new problem. This has been going on since Vietnam, as far as my understanding and my history of investigating this problem. So we know that every soldier that goes to war comes back with PTSD. Now, that's kind of anecdotal, but the reality is that about 30% of soldiers in combat who experience traumatic stressors and psychological stress are going to come back and have some type of mental health illness. Whether that looks like PTSD or not is a little bit different, right? But right now the data, and we're all academics, right? So we all require statistics. Right now the data suggests that about 30% of all people who experience the type of combat or the type of trauma you see in combat is going to come back with a mental health issue. On top of that, 60% of the people or veterans who have a mental health issue are never going to seek out mental health care. And those are numbers reported at the VA Department of Statistics. Pretty easy to find. And of course, there's a lot of references at the back of the slideshow that you guys can look all these things up too. So you're gonna have to take my word for it for now and then look it up on, follow that up with your background research later. So there's a massive problem that is extremely well known, that has been specifically quoted by every president since George Bush, saying that there is a mental health crisis facing our nation's veterans, and we are ill-equipped as a nation to deal with it, and that we need to raise awareness and end veteran suicide. So that has not happened. Now, what I see as the problem is that we're having this continued narrative where now healthcare workers are the new soldiers, and it's very easy for us to say things like, you're a hero. Dr. Z, this question's for you in particular. When you were in New York, at the time that you were there, I believe they had started doing this sort of hero ritual. At 7 p.m., they all sort of start clapping and honking their horns. Did you get to experience that at all?
I did get to experience it. I don't necessarily know how this fits in with your narrative, but I found it very powerful, a very moving experience. I don't know how you feel when kind of soldiers return and the plane lands and there's all these families and everyone's waving a flag. I imagine it must be similar, but it was a very powerful experience for everyone to
Yes.
pause their lives and just give acknowledgement to the healthcare workers.
Yeah, and that's exactly what we see as veterans returning from like combat missions or combat deployments. We'll have a number of civilians who are lined up in the airport greeting the veterans or the the combat soldier's back, and it feels like it feels righteous, right? Like you have this indication, like the thing that you've done is good. Unfortunately, this is the crack. This is where things sort of start falling apart. Those same people are the ones who are rioting in the streets about wearing masks, and they're sitting down throwing tantrums in a Costco because they feel like their freedoms are being violated. And those are the same people who are winding up in the second spike, who are showing up to hospitals now because of refusal to follow through on the promise. And we get that a lot. So in the military, this is the point that I'll bring up on the slides that we have here. There's a social contract that service members sort of sign up with, right? Like they know what they're getting into. When you go and join the military, you sign up, you go to your recruiter, he brings you to the MEP station, you raise your right hand, you swear into your oath, and you know exactly what you're doing because it's in the oath itself. You know, you're accepting the terms of the contract, and that is not limited to sacrificing your life in service to the nation in its defense. You know what that is. So what doctors haven't done is they haven't signed up with that contract. When you, Dr. Z, when you showed up and you decided to become a doctor, it wasn't so that you can give your life to your country, it was so that you could help people. And you can stop me if that's not true, but I believe that's absolutely true.
It's true. I guess I'm wondering, you know, so are you trying to say that maybe it's worse for frontline healthcare workers because they didn't necessarily know that they're putting themselves out there?
Well, right. So that's kind of that's where the parallel starts to split off. So we have this huge response of PTSD and prolonged mental health injury from combat operations and prolonged mental health stress. And what we know is that in the Vietnam era, those who were drafted had an even higher rate or higher incidence of PTSD and refractory PTSD following that. So the correlation is exactly as suggested by one of our members here in the chat. It's not just that doctors and service workers in this particular case volunteered for that duty. It's that they were drafted into a war that they did not volunteer for. And in addition to that, at the very beginning of this problem, healthcare workers experienced an institutional betrayal where they were then inside their facilities, inside their hospitals, and there was no longer the availability of PPE, all of the protective measures that usually existed that doctors sort of agreed to, like, I'm going to expose myself to high-risk situations, and I understand that as a physician and as a health worker. And what the agreement is that we're going to do it in a safe and controlled manner. And I think that was lost in your experience in New York. Did you ever experience the lack of PPE?
So by the time I got there, PPE was good. It was donated in droves.
Okay, so they had already gotten there.
Yeah, they had already compensated, and everyone had all the PPE that they wanted. So that was good. Kevin, what kind of solutions? We trying to take it back to a parallel. What kind of solutions have the military maybe offered that you think that could be offered for healthcare workers that we can learn and improve this kind of mental health disparity?
Yeah, so that's the big thing. And Ross, you want to kick it to the next slide there? Oh, we don't have the. Okay, so there's a whole strategy that the military has implemented as far as screening tools for dealing with and managing the stress of situations like this. They have pre-deployment health questionnaires, post-deployment health questionnaires, and there's a lot of interventions in play that exist as far as structural interventions to prevent mental health issues in veterans. that doesn't exist right now for our healthcare workers. They were not screened for the risk factors that exist for mental health issues on the front end. They are not being screened periodically every time they experience a psychological stress, a psychological trauma in the hospital, and then they're not being provided for on the back end. So all of the known protective factors that exist for things like mental health and PTSD are self-protective in nature, right? Like go home, take time off, see family, do a hobby, exercise, get fresh air. Well, there's a problem because all of that is eliminated in the context of COVID, right? It is, no, go home, but stay isolated. Don't see your friends, keep a social distance. All of the protective factors that the military employs to protect its veterans are no longer available to the doctors who are here. Not just that, but they feel obligated, morally and ethically obligated, to continue to do their work because they are, in fact, quote, essential people. They're essential workers. And if they do not go to work and continue to expose themselves to a prolonged threat to life, and also exposing their families to a prolonged threat to life, then people will die. And that is a point where most people begin to kind of fracture, and they experience things like moral injury, where they're not able to intervene in a positive way in either direction. So if they do go and help their patients, if doctors do go, or any healthcare worker, this is including any of the essential people in the health system, if they do go to the hospital and they take care of their patients, they are simultaneously putting their own lives and the lives of their families at risk. But if they don't go to the hospital and they protect their own lives and the lives of their family, then they are abandoning their patients in an agreement that they've made as a contract as a physician.
Yeah,
so there's no winning situation.
My feeling was a bit different in terms of, and you're right in that healthcare workers didn't necessarily sign up for this, but I did, right? I signed up. No, I was under no obligation to go to New York, and I felt a sense of kind of personal and professional fulfillment by going to New York. You know, I don't have a death wish, so I didn't put myself at any higher risk. I wore my PPE. I didn't do anything, you know, I didn't go to any large events or hang out with family or friends, but I did put myself at an increased risk by going to New York. I felt it, and so I did sign up for it in many ways. I could tell that there were many physicians there who did not sign up for it, and you know, they were older and had families and many comorbidities and were legitimately terrified about what was going on. So I had the opportunity to relieve them, but yeah, it was a little bit different for me. I feel like there were mental health resources there, and none of the, you know, I don't know how you deal with this in your profession, Kevin, but there were mental health resources and just no one really utilized them.
Yeah, so that's part of that last point I have here on this slide. It's the barriers to seeking mental health self-care. And in a direct correlation to military personnel, those things really do kind of overlap a lot, right? So there's individual barriers, social barriers, and then institutional barriers, right? I think the individual and social barriers that exist inside of the veteran population are very similar to what you see in the health field as well, right? So a lot of times doctors say like, oh, I'll be able to identify when I'm stressed or when I'm anxious or when I'm losing control. I'll be able to identify that because I'm a trained professional. But the fact of the matter that mental health care is a very insidious and kind of like, you know, very low latent kind of effect that maybe you don't really understand that this is taking its toll, or maybe that, or maybe the psychological stress isn't so worrisome now because you're so preoccupied with going into the hospital to do the work and to save your patients, and then you'll suffer the consequences of the moral injury or the psychic trauma later on. And the effects of PTSD generally don't present themselves, you know, immediately after the trauma. It's this kind of latent thing that grows and doesn't get well over time.
So
there's all these.
If I can interject for a second, we have a question in the chat that I think it leads to the next slide, but I think it's a good one. And that is, how can we being the general public, help support the mental health needs of healthcare workers and their families, either through systemic change or just being a family to family? What would you guys suggest that people do to help out?
Yeah, so that is the question. That's the major question moving forward. We've identified a correlation of the exact same type of stressors that we have seen in military personnel, given the fact that we are treating this like a military operation. So the risk factors exist for an enormous wave of mental health issues moving forward, and there's a lot of people who are actively trying to address this right now. Even institutions, and I'm not trying to say that the institutions themselves have dropped the ball here. Most hospitals already know that this is a problem and it's coming, and they're trying to get in front of it and intervene right now. As far as the institution and structural changes that need to occur, in my opinion, is a lot more screening, a lot more downtime, and a lot more scheduling that provides doctors and physicians more breaks. Just like in a military operation, if one particular unit has experienced a high stress combat situation, they don't send them back out tomorrow. They cycle them out. They send the guys on 2 weeks of R&R. They bring them to Qatar or Kuwait and give them time to sort of decompress. During that time, they're also evaluating them. They go through like a post-mission debrief, and then they go through kind of like a group therapy session for a number of weeks. And if institutions are providing that sort of thing, like inviting visiting doctors like Dr. Z to go to New York and replace doctors for periods of time so that they can go home and experience those generally protective factors, that's going to be the best thing that institutions can do. As far as the general public goes, my opinion is this: like, if you truly value the mental health, the life, and the sacrifice that these draftee soldiers in the healthcare system are doing, then you have to follow the recommendations of the health practices that are being put out state by state and nationally.
That's what I was going to say. I think that was the main point, and Kevin touched on that in the end. When you see kind of these videos of people going into Costco and refusing to wear masks and having these large gatherings and coughing all over the place, it's very mentally draining. It really is, for healthcare professionals who are really doing everything they can to kind of prevent the symptoms and the outcomes of this disease. So seeing people yelling and screaming about masks for whatever reason, it does take a toll on healthcare workers.
Yeah. So Dr. Z, that's the clapback when you have the problem of the big response when you return from combat, and the flags are waving and everyone's clapping and you're the hero of the day. That feels great, and that is exactly why I mean, not for the individual praise, but because soldiers know that they're doing something good, right? When they know that they're going out and sacrificing of themselves in the defense of the nation, it feels good when the response of that nation is, yes, you did a good job, thank you, hero. But then when that is immediately followed with, but also, I don't care about you, I don't care about your life, and I'm going to continue to do what I want with my freedom, it tosses all of that right into the trash can.
And I know that recommendations change, and it's pretty frustrating. I get it when kind of these mandated recommendations change, but information changes all the time. The data on COVID changes all the time. So as long as I get a sense, and healthcare workers get a sense, that we're all trying to do the best we can and we're all on the same team, I think that's very helpful and very good for mental health, to get a sense that we're all on the same team. So anything you can do to kind of show that you're on the same team as us is just so wonderful, because in reality, we are all on the same team. We're just trying to beat this thing. together so we can get back to our families and get back to our concerts and our events. So we're all just trying to beat this thing together. Ross, I can't see the chat very well.
Okay.
And I think, so if you just, why don't you moderate, and
Okay.
if there's any interesting questions for myself or Kevin, just why don't you go ahead and say that.
All right, there's a bunch of questions, and please, to our audience, please keep in mind, they may not have the answers to these. Some of these may be above their pay grade, or they just may not know the answer. So both Kevin and Dr. Z, if you guys don't know, just say move on, and we'll move to the next one. Let's see here. We have a question from, looks like a parent that would say, what about team sports like soccer or basketball? Does it make a difference if you wear a mask during those activities?
Yeah, so always wearing a mask is going to be the best. I'm not sure. I think team sports, are they recommending team sports yet? I think we're probably not recommending team sports at this time. But if, you know, mask is always going to be better than no mask. It prevents respiratory droplets from getting out, and it prevents some inhalation of respiratory droplets. So it is protective to wear a mask, absolutely.
All right. In that same vein, for Dr. Z, what are your thoughts on the recent WHO statement on possible aerosol transmission of the coronavirus?
So that's, you know, in laboratories, it has been shown to transmit by aerosol. So that's why we're doing kind of airborne precautions in as much as we can by wearing masks. And in the ER and highly aerosolizing procedures like intubations, we wear very heavy duty masks. So yeah, in the laboratories, it has been shown that it can linger in the air. Whether that makes sense for a transmissibility on an epidemiological sense, I think the data is still not 100% on that. But it's very concerning that in the labs, it does show that it aerosolizes.
We have a question from a very famous biomedical scientist, Dr. Neil Schiller. Dr. Z, in your experience, is remdesivir helpful in treatment or any other antiviral agents?
Remdesivir is the promising one. That is one that we're giving to pretty sick patients. The supply is pretty limited, so we don't have a lot of it, but it's good. It's promising for really sick patients. That's about the best antiviral that we're using right now. There's some protease inhibitors and Tamiflu that were initially thought to be okay, but the data is just not there.
Question regarding the patients who are choosing not to be ventilated. Why do you think patients were choosing to die rather than being ventilated or intubated?
So I suppose you have to ask the patients that, but you know, DNI or DNR is a common decision that patients make, be it their religious beliefs or whatever they want, you know, as far as life support. Some patients have a view on futility of life support. Some patients just don't want anything invasive done, and that's their wishes. So it's hard to know exactly the decision, but yeah.
Sorry, Dr. Z. Can I add to that one? In addition, this is a common occurrence as far as any chronic illness goes. There's almost always some kind of comorbid mental health issues stacked on top. So you're talking about people who are very sick or chronically ill, who are very likely suffering from a major depression anyway, who are coming in, and now they're being told that not only are they still ill from whatever disease they've had, whatever comorbid disease process that's been afflicting them for a number of years, but now they are even more chronically ill and now acutely ill, and they're going to have to be intubated. A degree of mental health that's already worn them down is probably contributing to that in some degree, where they would be less likely to accept treatment because they have untreated or unaddressed mental health issues likely at play.
Thank you, sir. Sorry, go ahead.
Yeah, I disagree with that. I think patients make these decisions often very rationally and come to these decisions from a lot of deep thought and have thought about this quite a bit and make very reasonable decisions about their own wishes, medical wishes, based on all the information that they have. And often it's a very tough decision for them to make. But I think they make it not necessarily out of mental health issue.
Well, I agree that it's probably not entirely mental health. I think that there's a lot of contributing factors, though. I think that's one of them. I think the absence of family, the inability for some of these folks who are now in the hospital without having their family available to them. Maybe they are making the decision independently instead, where they would generally have spoken to their family about the group wish. I think that there's just a different kind of context where the decision is being made that's contributing to this directionality of where you're seeing people refusing intubation.
So let me jump in because we have several variations of this question being asked. What are your opinions on reopening schools and childcare centers, campus, etc.?
So unfortunately, these questions have become way more political than I had ever anticipated or thought they would be. The answer to these questions, I think, is strictly epidemiological. At least they should be. So when cases go down, then the health professionals who are above my pay grade need to make this decision on when it's safest to open up these schools. There's always going to be an economic kind of economic hardship with keeping all these things closed. But this is a decision that is far beyond me. It's about weighing the medical benefits versus economic hardships of doing these things.
And in that vein, Dr. Z, do you think it's safe, you personally, do you think it's safe to attend a gym or go to a gym pool with a mask?
Well, a pool with a mask is going to be very irritating. I don't know how that would even be done. So gym, it's a tough question. Me personally, I would say no. This is where people all breathing, coughing, and sweating on each other. That being said, there are gyms that are opening up, and people are going to make their own decisions. So it's just about doing the best that you can. If you're deciding you're going to go to a gym, I'm going to say maybe don't go to a gym. But if you're saying I want to go to a gym, I'm going to a gym, then do the best you can. Wear a mask at the gym. Stay away from at-risk populations. Shower and change immediately when you get out of the gym. If that's a decision you're going to make and do. Obviously, I recommend you don't go to the gym until kind of state and health officials have deemed that it's a lower risk. Once you get a sense of why coronavirus cases are going up, and until we get a more robust treatment, I think that's a pretty high risk thing to do. But that being said, if you're going to do it, be smart.
Okay, and two similar questions. Are you noting the surge in Riverside County is now a younger population? Are these patients experiencing milder symptoms or a real mix of mild, serious, and critical? And in that same vein, what demographics are you seeing getting severe infection from COVID?
So what I'm noticing is similar to previous COVID infections. It's going to be older populations. It's going to be people who don't monitor their health as well. People who have a lot of comorbidities. They're coming in with milder symptoms. We're going to discharge. We're going to discharge immediately, and we're going to hope that they don't come in, because once you come in, you're inoculated with more virus. So if you're mild and you're not requiring oxygen, we're going to discharge you. We're going to evaluate you and discharge you. The people who are staying in the hospital are people who are requiring oxygen and needing more and more oxygen. new data is showing that we should probably not be putting these patients on ventilators, and we should try to support their own breathing mechanisms with high flow oxygens and different kind of therapies like that. So that's what we're doing, and we're admitting patients with non-rebreather masks and high flow nasal cannulas and those kinds of things to help their breathing.
And we're going to go speed around because we'll try to get through as many of these as we can, but I feel like we're getting new ones as fast as we're reading them. So is there any evidence that a blood type plays a role on who is more susceptible to the virus?
There is some evidence. There is some evidence that O blood is, they're safer. Generally, it's not great data, so it's unclear why that is. They think there might be some binding sites with the virus. There might be some antibodies that are helping protect a little bit when you have O blood, but there is a little bit of evidence. Again, correlation does not mean anything about causation. Who knows? But there's a little bit of evidence.
Are you seeing differences with exposure to viral load in regards to severity of the disease and immune response?
Generally, yes. So generally, that's why healthcare workers are at higher risk, because their inoculation is thought to be higher. You don't necessarily see that in the emergency department. We don't know when somebody comes in how much they've been exposed. We know what their symptoms are. We know how bad they're doing, but it's very hard to relate that to their exposure to their inoculation dose. So in theory, yes, but in practice, it's hard to know if the amount that you're being infected with is playing a part.
A question about N95 masks. Is it true that N95 masks not only protect others, but also help defend the wearer? If so, why not advise all to wear N95, or is there still a shortage for healthcare workers?
Yes, so N95 is a more expensive and less available mask. It does filter out 95% or 95 micron, hence why it's called an N95. It's better, but it's not as available. It's sometimes harder to breathe for healthcare workers, less comfortable if you're wearing them all day. So it is institution dependent and provider dependent, but for not highly aerosolizing procedures and COVID patients that are coughing everywhere, it's okay likely to wear a surgical mask is good and a comfortable option and a safer option.
Is it true that young kids don't transmit the virus if they get infected?
I have not heard that, and it sounds highly suspicious to me, to be honest. I have not heard that, but I don't see why a child can't transmit it as much as an adult. But I don't know. I have not heard that.
How do you suggest we communicate with friends and family who are not taking the virus seriously, not wearing masks, going to gatherings, etc.?
Well, I think Ross can provide them a recording of this lecture. One thing, you can YouTube any amount of New York City healthcare workers who say that this is the worst thing they've ever experienced in their entire lives. Unfortunately, there was a colleague, Dr. Breen, who in New York City, I don't know if you heard the story, but when I was there, she was an emergency physician that was so stressed out that she killed herself. And this was a Columbia, New York City ER doctor whom I had heard of. I haven't known her directly. So that's the stress that she was under from the COVID.
It's also my understanding, Dr. Z, that she had contracted the virus, became well again, and returned to work following becoming healthy again. And then that was another contributor to her.
Not because I know her personally, but We had trained with similar people. We work in similar ERs, and we could have been the same person. She was very well respected. She was a very, very good physician, and that's how hard she took what was going on in the emergency department around her. She felt she lost control. Patients were dying, and there's nothing she could do about it, and she took it very emotionally. And so if you have somebody who's not taking things seriously, you can maybe point to this physician, in New York City who, probably took it too seriously and really suffered.
Well, in that vein, as a follow-up, how have you seen screening for depression being implemented at RCH or other healthcare places for healthcare workers?
So we have a very helpful and supportive kind of staff at RCH, and they don't necessarily have screenings, but if there's anyone who needs to speak to someone or needs some time or is not doing well, there's always colleagues at RCH who are going to be supportive and helpful. There's mental health resources, and if I tell my bosses or anyone that I need some time, some personal time, they're all very willing to accommodate, and people will take my shifts, and it's been a very supportive environment for me in my current job.
We'll go a few more. This is a question that's been asked more than once. What are your thoughts about finding an effective vaccine? Do you think one will be found soon, or what are your thoughts?
Oh man, I hope so. It's hard to know. There's a couple vaccines that are, I think, phase 3 clinical trials, which means another. So they've passed safety, and so now they're going on to efficacy, and so we'll see. Those trials end in about 4 or 5 months, so we'll get a sense of what the landscape looks like. It's hard to know. I hope that there will be a vaccine soon.
This question is more general about viruses and germs, but what impact is there to our immune system by staying away from germs? This individual says they typically don't use hand sanitizers or things like that.
What impact is there from staying away from germs?
Basically, I guess the question is, can you wash your hands too much or be too sanitized?
The answer is no. Okay, let's say, I think you're talking about probably germ theory, which maybe for years and years growing up, you may not want to do those things. But in the current pandemic and COVID crisis, no, there's no such thing as staying too much hygiene, too sanitized. We could talk about the difference between being too sanitized and too much hand hygiene, for 30, 40 years, or maybe growing up for 15 years or something. But for the current crisis, no, there's not going to be a point where you're doing it too much.
And I'm actually glad Dr. Schiller's here to hear me say this, because it's a little validating to his instruction to me in my second year there. But given the situation that we have right now, you're at much greater risk to contracting the COVID-19 or SARS-CoV-2 virus than you are of washing away your bacterial or viral resistance. So given the situation, as far as just risk stratification goes, everyone needs to wash their hands as often as they can to prevent the spread of the virus.
Yeah.
100% agree. Okay, so you all heard it. Go wash your hands, use hand sanitizer. What things can we do to boost our body's immunity if we come in contact with the virus? I've heard vitamin C and zinc are a couple of things, but anything else you can suggest? So what should people be doing besides washing their hands and wearing a mask?
Yeah, so supporting your immune system is great. And there's a lot of trials and a lot of talk about vitamin C and vitamin D and zinc. And so it's important to not be deficient in those vitamins. It's very important to I think taking a multivitamin daily is a wonderful idea. I don't think it can hurt. So I think if everyone takes a multivitamin, it's going to be helpful. As far as the data goes, it's not super strong. We do know that zinc deficient patients do worse. So taking zinc is not a bad idea if you're zinc deficient. Whether that means that taking zinc will help you prevent COVID, probably not. Who knows? Vitamin C is water soluble, so the more if you take too much, you will end up probably just peeing it out. But it's important not to be vitamin C deficient. So healthy diet, checking vitamin C levels potentially, and then taking a multivitamin. Vitamin D is about the same. So making sure that you're not vitamin D deficient and taking a multivitamin, making sure you get your sunlight, those kinds of things are very, very important.
We have several questions about vaccines. We're going to go about 3 more questions, I think, for time, but I'm going to combine them all and then let you guys talk about vaccines. Can a mixture of both vaccines and antibodies help get us back to normality? Question 2 is vaccine. Would you take it immediately or wait? And question 3, would you not be worried of side effects or the fact that it's a rushed vaccine?
Well, that's why we have to make sure, I suppose, that it's not a rushed vaccine and that we don't, jump the gun and just start injecting people with vaccines, that we make sure it goes through the proper process with the FDA and the proper clinical trials to make sure that it's safe. You start with small populations, large populations, those kinds of things, and monitor very closely. I do think it's important to not jump the gun. I very much believe that. And having a passive immunity by giving antibodies is great. And it could help if we find the right, that's kind of the idea behind convalescent plasma, is that you can give somebody's antibodies and help with that immunity. But it's not long term because you don't develop your own immunity. So once those antibodies are out of circulation, you're essentially going to get the virus again. So it's important to build your own immunity using a vaccine. That's how you get more of a long-term solution. So as far as combining it goes, I don't know about that. I think once you have a vaccine, then it's good. Unless you're sick, and then you might need antibodies. So it's kind of for 2 different situations.
We have some questions about testing. Will testing be necessary for the whole population? And if someone has not, or is fairly sure they have not been exposed to COVID and they generally stay home, should they go get tested?
Why not? Yeah, go get tested. No, I think knowing your situation is going to be great. You don't necessarily have to if you're kind of committed to staying, inside and quarantining and you're asymptomatic. Yeah, I suppose you don't need to. And a lot of it depends on availability, right? So when availability goes down, then people such as, asymptomatic people quarantining don't need to get tested as much. But hopefully the availability of tests goes up. And in that case, I don't see a reason not to know your status.
And our last question, and I apologize everybody, we did answer, but we've gone through 25 questions, so I think we've done a great job. And this is for both of you. How do you think this crisis, and ones like it potentially in the future, will impact healthcare, especially positions like medical ethicists and palliative care?
So I want to know what, Kevin is training at this crazy time. I want to know what Kevin has to think about how this is going to impact his future as a resident, as an attending, as a healthcare provider.
It's actually a pretty good litmus test to determine, in my opinion, sort of the drive and motivation for training docs right now, at least as far as students go. In my experience at my level here at UCR School of Medicine, there hasn't been a single question about the motivation or what drives us moving forward in our training. The 4th year class that just graduated right now, every single one of them happily accepted their accepted their match placement, and they are all excited to have started working last week. They know what they're getting into, and I think that is exactly kind of what's going to protect them moving forward. It's difficult because there already is a very well-known physician shortage nationally as far as the number of patients and available doctors to treat them. It's hard to tell how many more people are going to want to pursue a career in medicine if this isn't handled well. Maybe it's something that you do consider before you enter into a nursing program or a physician training program, if the way that, or the national response is mishandled in this situation. So long as institutions are placing their training and the protection of their students up front. I speak exclusively from my experience here at UCR, and I know that this is happening across the nation. There's really a collective response to it, where all training institutions and training programs have really gotten together and communicated openly with each other. There's a lot of trust that we have in our administrators here at the school, and so far I haven't seen any negative consequence in the student body in my experience here as far as the physicians in training go. And I love that. That means that everything is working. That means that what we're seeing as the response to this is adequate, and it means that the trust that we have moving forward is that the doctors and the healthcare workers will be taken care of. There is a matter of awareness, however, that we are now, in fact, at a higher risk than other doctors who have trained before us might have been. Now we are at higher risk of different things like mental health considerations that maybe other doctors haven't had to experience before. All of those things put together mean that our particular cohort needs to be very considerate of what it means to be a trainee in this situation, just like the doctors who are already in practice need to self-evaluate and where they are as far as their mental health goes as well. It's very promising moving forward, though.
Can I ask, in your speaking with your colleagues, has anybody changed their thoughts about where they might choose to do a residency, or what field they want to get into by virtue of living through the COVID pandemic?
Yeah, so anecdotally, as far as my experience with my cohort, there hasn't been a lot of shifting around. If there is an individual who has shifted off kind of what they thought they were going to do as far as their career goes, it's been exclusively because of the training as it stands, right? Like maybe they did an ER rotation, found out, actually that's a little bit a different lifestyle than I'm willing to accept as a career. But as far as the COVID crisis goes, there hasn't been, as far as I've been aware, anyone who has made a decision as far as their career moving forward based exclusively on the response to the COVID crisis. That's probably reflective of the school's adequate response or the hospitals that we're working at and training at. But there's a high degree of confidence from the student body.
And I'm going to ask one more quick question to Dr. Z, because there's so many other questions out here. Where would you recommend people go for legitimate, accurate information about COVID-19 and what they should be doing? What is a resource that people can go to, that a layperson can go to get data and information that is correct?
Yeah, it's tough, right? Information's changing all the time. My information comes only from health official websites, like the Riverside County Health public health website and the CDC and those kinds of resources. I don't do anything with regards to news and what they present, because I don't know what can be trusted or what can't. So I think the public health websites for Riverside is fantastic. That's what we use. We use just that website to kind of guide how much resources we need and what's, whether the next wave is coming. So we use only official Department of Public Health websites.
All right. Well, with that, we're 20 minutes past our time. And even though y'all can't applaud, if you want to send a message in the chat, please give a big thanks to Mr. Kevin Westbrook, soon to be Dr. Kevin Westbrook, and Dr. Sam Zidovetzki for their time. And I want to add, Dr. Z pulled a double shift yesterday at RCH, didn't get home till 10 o'clock last night, and was still able to make this presentation today for y'all. So know that he is working hard out in the community, and he hopes he doesn't have to see you in the emergency room at RCH. So thank you, gentlemen, very much. Thanks, everybody, for attending.